Hi guys, hope you're all doing good. Now today we are connecting to learn about Behcet syndrome. The first thing that comes to mind when we say Behcet syndrome is that this is a condition which is classified as variable vessel vasculitis, right? Variable vessel vasculitis. So that means there may be involvement of different types of vessels or different sizes of vessels, right? So this is a disorder where it is characterized by both involvement of arterial as well as venous side of the vessels. It is also characterized by involvement of different sizes of the vessel, right? That is basic about Behcet syndrome. So when we say variable vessel vasculitis, right, there is only other condition that comes to my mind is Cogan syndrome. That is the second example for variable vessel vasculitis, right? Okay, so today's focus will be primarily on Behcet syndrome. Right. What is important for us to learn from this topic? I particularly want you to pay attention to epidemiology, right? A direct question is likely because there is a striking epidemiological variations. The second thing I want you to learn is the organ systems involved and what are those characteristic manifestations. The third thing I want you to learn is the management primarily with a syndromic approach or phenotypic approach. These Behcet syndrome cases, we can classify them into a different phenotype. For example, it may be a mucocutaneous phenotype, or it may be a ocular Behcet, or it may be a neurological Behcet. So we have different approaches for them, right? That is the third area I want you to focus. The last and equally important is the diagnostic criteria, right? So when we have a patient, how do we approach the diagnosis, right? These are the four areas to focus. So let us first begin with the basic introduction, right? What is Behcet syndrome? As we have discussed now, it is a variable vessel vasculitis, but particularly right now I want you to remember, yes, this is definitely a variable vessel vasculitis, but primarily it affects small vessels more than medium or large vessels, right? Small vessels are more affected than medium or large vessels. Okay, yes, it can affect arteries as well as veins. Right? Artery involvement as well as vein involvement is known to occur. Peculiarly, it is affecting small vessels more than medium or large. So when we go on to discuss different organ involvement, so bear in mind, majority of those manifestations are indeed because of the small vessel involvement, right? Okay. Now, one important MCQ that can be asked from this topic is again, what are those manifestations where there is a medium or large vessel involvement, right? So when it comes to arterial, medium or large vessel involvement, the most common manifestation is pulmonary artery aneurysm, right? This is a very important potential MCQ point, pulmonary artery aneurysm. So I want you to remember this. Okay. Now, how these patients are going to present to us? These patients usually present. This is a typical presentation, and again, bear in mind, it need not be that all patients should have these manifestations, right? But in a typical story, patient would present with recurrent oral ulcerations, recurrent genital ulcerations, and eye inflammation, right? So when this triad is present, the diagnosis of Behcet syndrome is very, very easy. But in the absence of that, yes, you still might have to consider diagnosis because none of them are absolutely essential criteria for diagnosis. Okay, I hope the point is clear. Now coming to its epidemiology, right? This is a disorder which is also called as Silk Road or Silk Root disease. Silk Road or Silk Root disease. Why so? Because the prevalence is significantly higher in terms of geographical distribution in the erstwhile or ancient days Silk Route, right? Those who are not very much familiar with history, let me remind you that Silk Route primarily connects some part of the China, part of India, and the part of Gulf world, right? Primarily Iran and Turkey. That is where the Silk Route is found. So the disease incidence is significantly higher in this belt, right? Now, among those countries which fall under the Silk Route, right, which can also be called as the Mediterranean zone, the highest incidence is reported from Turkey. Right? Turkey reports the highest incidence. And also remember the guy who first reported this disease, or what we call as Behcet, right? The Behcet was a Turkish national. The disease typically affects both young males and females, right? So the prevalence is between males and females is 1:1, right? It can affect both the gender equally. There is no gender predilection. But if you look at the geographic distribution, gender distribution, one thing you will clearly notice is that males, especially those who develop the disease in the young age, are going to develop more severe disease in comparison to females, right? So female gender is kind of protective against the severity of the illness. The typical age at diagnosis usually falls between 20 to 40 years. Okay, so that is the basic epidemiology. Now let us look at the pathogenesis. Okay. Now, when it comes to pathogenesis, I want you to remember one point. The point is, we really don't know much about its pathogenesis, and this is one disorder which is at the crossroads of being an autoinflammatory disorder and an autoimmune disorder. Right? Now, we were talking about this Mediterranean, right? So we already know one important autoinflammatory disorder that is called as Mediterranean fever, right? That is an autoinflammatory disorder, not primarily autoimmune disorder. Now, when it comes to Bessay, right, this can neither be classified purely as an autoimmune disorder nor purely as an autoinflammatory disorder. It is something in between. That is the basic point for us to know. Now, in terms of pathogenesis, I have already made it clear we don't know much about it, but we have certain observations which may be having some pathological consequences in the future. As of now, we don't know what exactly these observations mean to us. We have noted that these patients have antibodies against alpha enolase of the endothelial cells, right? Probably that explains maybe the vascular injury that we see in these patients. We have also seen antibodies directed against selenium binding protein and ASC, right? Anti-Saccharomyces cerevisiae antibody. Where else we hear about it? Right, we hear about it in patients with Crohn's disease, right? So right now I want you to remember this point. We do see anti-Saccharomyces cerevisiae antibodies in these patients. There is some more correlation to learn for us. We will learn as we go along, right? But all these observations, currently we cannot put the pieces of the puzzles together, so we don't know what is the pathological role of these observations. There are also studies which strongly implicate herpes simplex virus as well as sanguis, right? These two, the bacteria as well as the viruses, have been implicated in pathogenesis of Bessay syndrome. Okay. Now, coming to genetics, that is something particularly interesting for us. What is interesting? We know that we have this HLA-B51 mutations, right? This was long known and all recent studies have also confirmed it. But remember, this is not mandatory for the diagnosis, though we know the strong association between the risk of developing Bessay and HLA-B51, right? Now, this is not mandatory for the diagnosis, and at the same time, having HLA-B57 doesn't mean that the patient is going to develop Bessay, because this Silk Route population, right? A good number of them, maybe 10 to 15% of the patient population has HLA-B51, right? But not all of them have Bessay syndrome, right? Okay, so that is the point. Other than that, a lot of Jiva studies have identified polymorphism in interleukin 10 as well as the shared interleukin 23-12 receptor loci. Yes, there are certain correlations there. Okay, so that is about basic genetics. This is one point to note, HLA-B51 and its association. Now, coming to its clinical features, right? Let us understand clinical features organ by organ. What is the most commonly affected organ? If the question is asking you, the answer is straightforward, that is oral, right? In fact, if you go on to see or take a look at the diagnostic criteria, most of them, not only the one that I'm going to discuss, there are a lot of other diagnostic criteria. Most of them say it is kind of mandatory or a prerequisite for considering the diagnosis of Bessay to have oral lesions. Right? So this is the most commonly affected organ. What is the manifestation? Patients develop recurrent aphthous ulcers. There are certain points that I want you to note. The point number 1, the ulcers are painful. Ulcers are painful. If you look at the ulcers, you will notice that it will have a central necrotic zone, and surrounding that there is an area of erythema, a classical aphthous ulcer. Central necrotic zone and erythematous rim. Now, when it comes to these oral aphthous ulcers, it can affect any part of the oral cavity, right? Any part of the oral cavity, tongue, cheek, any part of the oral cavity, it can affect. And the usual oral ulcers are small. They are not large, right? They are small, lasting for less than or ranging for less than 1 centimeters in the maximum diameter. Yeah, in rare circumstances or more severe disease, maybe a larger ulcers may be seen, but in general, overall, the ulcers are small. Okay, and even in case of the oral ulcer, the ulcers are not very deep either. They are not very deep either, and that is why most of those ulcers usually heal in 1 to 2 weeks time with no scarring. Again, remember this point. They heal with no scarring. But the same rule doesn't apply when we go on to discuss the genital ulcers, right? So here the ulcers are shallow. They're not very deep. They're not very wide, right? Less than 1 centimeter or 10 millimeter. Depth is also not very large, and they heal within 1 to 2 weeks of the onset without leaving behind scars. That is about oral ulcers, right? And any part of the oral cavity can be affected. So basics are clear. Now, coming to genital ulcers, right? So when it comes to genital ulcers, the involvement is less frequent. Oral, as we said, it is the most commonly affected site, But in case of genital, the involvement is less frequent, but it is more specific because there are various other causes for oral aphthous ulcers, right? So genital ulcers may be some STDs, and then comes the Bessel, right? So you have a right clinical context, you see genital ulcers, that is more of use in terms of diagnostic confidence in comparison to having aphthous oral ulcers, right? Less frequent, more specific than oral ulcers. Here also ulcers are going to be painful, but remember they usually heal with scars, right? The most commonly affected sites in male is scrotum, in female it is usually the vulva, right? So it heals by leaving behind a scrotal or vulvar scars because generally these ulcers are much more deeper than the oral cavity ulcers. Okay. Another point to note here is the ulcers in the genitalia usually spare glands and urethra. You can see some patients with the ulcers on the glans penis, but that is an unusual finding, not a routine thing to occur, right? Having ulcers in the glans penis is an unusual finding. So in this image, you can see scrotal scars, right? Typical like what we saw in the previous. There is a central necrotic scar. Not much of erythema visible here because it is now showing a healing process or a scarring process. But the ulcers are very much evident that they are much more deeper than what we saw in case of oral ulcers, right? Look at the ulcer here and look at the ulcer here, right? So this will obviously heal leaving behind scar, right? Okay, that is about genital ulcers. Now coming to the other skin manifestation, the dermatological manifestation, there are 2 or 3 important points to note. Very often patients present with recurrent acneiform eruptions, right? Like the pimple-like or acne-like eruptions, which can be more on the face as well as the back and the other parts of the trunk. The lesions typically resemble what acne would look like, right? So that is why we call them as recurrent acneiform eruptions. And this is one of the very common finding, in fact, in these patients. The second thing I want you to note is, what do we see here? Something similar to acne looking, right? Now, this is what I call as sweet syndrome. What is sweet syndrome? Sweet syndrome is a acute, right? The points to note, words to note, acute febrile neutrophilic dermatosis, right? Acute febrile neutrophilic dermatosis, right? So this is basically a acute manifestation, unlike the acneiform eruptions, which will occur as a chronic manifestation, like slowly new lesions would be appearing. Here the lesions are appearing all of a sudden, right? Not exactly sudden, but yeah, in an acute fashion. So this is an acute. Patient will have fever at the time of presentation, and if you biopsy, you will notice that there is intense neutrophilic inflammation, right? Acute febrile neutrophilic dermatosis. So this is an acute manifestation. These acneiform eruptions are rather a chronic occurrence, right? Okay. The third point to note, what do we see here? I've already mentioned it is pyoderma gangrenosum, right? Now, where do we actually hear pyoderma gangrenosum? We hear in patients with Crohn's disease, right? Okay. In the earlier slides, we were discussing about some of these patients having anti-Saccharomyces cerevisiae antibodies, right? So that is a correlation. Anti-Saccharomyces cerevisiae antibodies are seen in these patients. These patients also develop pyoderma gangrenosum, right? And also remember, these patients may have a Crohn's disease-like manifestation or Crohn's disease-like presentation. So sometimes it is really challenging or difficult to distinguish between Crohn's disease and Bessel syndrome, right? Because in patients with Crohn's disease also, oral ulcers are known to occur. So patients with Crohn's disease can also develop genital ulcers, right? So sometimes it is really, really difficult to distinguish between Crohn's disease and Bessel syndrome. So that is one of the important differential diagnosis. Okay. Anyway, if you are diagnosing someone as having Crohn's disease or you're confused between Bessel and Crohn's, that phenotype, right, a Crohn's-like phenotype Bessel syndrome will also be treated like a Crohn's disease. Okay. So nothing much to worry there. Okay. Now coming to one more and particularly important manifestation, that is Pathergy test, right? What is Pathergy test? You take a needle. Usually we take a 20 gauge needle, right, and prick the skin. Now in a normal person, what happens? The skin is pricked. There may be a little bit of bleeding and it heals. But in patients with Bessel syndrome, the healing, before healing occurs, they develop a induration, right? In the early phases, they develop induration, and later on, you may also notice that the prick site develops pustules, right? This prick site develops pustules. So this is what is known as Pathergy test, right? So it is said to be positive when a induration appears or when there is a pustule form, right? Pustule formation is more characteristic. This is something which is peculiar, or I can say relatively specific for Behçet syndrome, right? So in fact, the diagnostic criteria also utilize this relative specificity of pathology test, right? So this is part of many diagnostic criteria. One of that we will be discussing soon. Okay, so these are the skin manifestations. Now coming to musculoskeletal manifestation. So there is a phenotype where there is mucocutaneous and musculoskeletal manifestations are occurring in cluster. Right? Okay, what are the musculoskeletal manifestations? These patients develop mono or oligoarthritis, right, which is very often acute rather than chronic. Right? So I was talking about sweet syndrome, that was also one of the acute complication or acute manifestation. Now we are talking about a musculoskeletal complication or manifestation which is acute, right? Monoarthritis or oligoarthritis primarily affecting the lower limb large joints, right? So knee, ankle and hip joints are typically affected, lower limb large joint, and this arthritis is going to be non-erosive, right? So it is going to be non-deforming, non-erosive, acute mono or oligoarthritis affecting the lower limb large joint. That is the classical presentation. Okay, now that is about musculoskeletal. Now coming to probably the most dreaded organ involvement, that is CNS involvement, or you can say neuro-Behçet, right? Neuro-Behçet syndrome. Now, this is not very common, but when it occurs, it is really difficult to treat. Right? So, this affects around 10% of the patients, and this involvement can be classified into parenchymal, where patients are developing the brain parenchymal lesion, which is more common, seen in almost 80% of the neuro-Behçet patients. Right? On the other hand, we also have non-parenchymal manifestation, which is primarily about the vein involvement. Right? So, in the very beginning, we were learning that in patients with Behçet syndrome, both arteries as well as veins are affected. Right? So when I say non-parenchymal brain involvement, it is primarily about patients developing the cortical vein thrombosis, right? Cortical vein thrombosis. The most commonly affected cortical veins are basically superior sagittal sinus and transverse sinus, right? These are more commonly affected, and definitely they develop thrombosis. That is the manifestation. Okay, so that is about neuro-Behçet. Now coming to GIT, right? So first thing we already know is that patients already develop oral cavity aphthous ulcers. Similar aphthoid or aphthous ulcers can develop in any part of the GIT, right? So any part of the GIT can be affected. Okay, so that is one basic to note. And in terms of histopath, right, those lesions of the other part of the GIT, histopath wise, they may resemble Crohn's disease. Right? That is why I told sometimes it is really difficult to distinguish between Behçet and Crohn's. Right? Okay, so that is about the GIT involvement. Now let us look at the ocular Behçet. Right? What are the usual findings we see? Right? The first finding I want you to note is that the characteristic eye involvement is in the form of pan-uveitis. So when we said that triad of Behçet syndrome, right? When I said eye inflammation, I was mainly talking about pan-uveitis. Okay, that is one. Now, other than that, significant number of these patients may not have pan-uveitis but may have a restricted uveitis. In that case, posterior uveitis is more common than anterior uveitis, right? So, the characteristic eye involvement is pan-uveitis, need not always be seen as pan-uveitis. This may also be seen as posterior uveitis, right? Posterior uveitis. Some of these patients, so we can appreciate in this image, there is uveitis present, right? Some of these patients may also present with hypopyon. So in this image, you can appreciate the hypopyon here, right? So these are the ocular manifestations. Now, when it comes to this organ involvement, right? So barring those severe systemic involvement like the neuro-Behçet, otherwise the long-term prognosis is not that bad. The mortality, it is difficult to attribute. Most cases of Behçet do not die because of Behçet, right? That is what we know as of now. But there is significant morbidity in most of those patients, especially those who have ocular phenotype, right? These recurrent uveitis can be vision threatening, right? So there is a significant morbidity because of ocular Behçet. So this is one point for us to note now. Okay, so this is about the ocular involvement. Now let me take you to the diagnosis. We have covered most of the organ involvement. We have covered the GIT. We have covered the involvement of eyes, skin, right? So now let us learn about diagnosis. When it comes to diagnosis of Behçet, right, just like how we have the classification criteria for various rheumatological disorders, we have one for this. Like there are so many others, but we will be primarily talking about the one that is most commonly used. That is International Study Group for Behçet disease, right? Diagnostic criteria put forth by ISGBD. Now, what does diagnostic criteria say? Okay, this is called diagnostic criteria, but this is essentially a classification criteria, or I would say it is more like a classification criteria which is supposed to guide recruitment of cases for the studies rather than help you or make it easier for you to diagnose a individual case, right? So I want you to remember one point. In the ISBGD diagnostic criteria, recurrent oral ulcers are a mandatory criteria, or you can say a prerequisite. The first criteria is patient should have recurrent oral ulcers, and if he is having 2 out of these 4 manifestations that are now going to be described, then you would be diagnosing this case as Behçet syndrome. But remember one point, this recurrent oral ulcers may not be there in some subset of patients. So I have seen one patient which was actually a Turkish national which had come for some cardiac surgery in Bangalore, and he did not have recurrent oral ulcers. He had all other manifestations, right? So around 10% of the patients, the initial presentation, in fact, for the remaining 90% of the patients, the initial presentation is with recurrent oral ulcers. But in those 10% where there is no initial recurrent oral ulcers, they may not initially meet the diagnostic criteria, right? So I want you to just remember this point. You can diagnose Behçet's disease even in the absence of recurrent oral ulcers. Second point, if you have Turkish friends as physicians or doctors, they would probably tell you that it is really challenging or difficult to diagnose this entity if you don't know that you are in Turkey, or if you don't know that your patient is a Turkish or a Mediterranean descent, then it is really difficult or challenging, because the oral ulcers and genital ulcers or the eye inflammation, this triad need not occur simultaneously, right? It is very, very rare to see a patient having all these 3 manifestations simultaneously. So it's like at some time he would be presenting with the recurrent oral ulcers, then many months later he may present with the recurrent genital ulcers. So if you are not connecting the dot, it is really difficult to diagnose. Okay. Anyway, coming back to the diagnostic criteria, the number 1 is recurrent oral ulcers plus 2 of the 4 of the following manifestations. Right? The following manifestations include recurrent genital ulcers. We already know the characteristics of the genital ulcers. Then characteristic eye or skin lesions. Right? That is the number 2 and 3. Characteristic eye lesions, we know what is that. That is pan-uveitis. If not pan-uveitis, then it should be posterior uveitis. Then what are the characteristic skin lesions? We have already discussed about it. Now the last one is pathergy test, right? Pathergy test positive. We know how do we do the pathergy test and how do we interpret. So if that is positive, if 2 out of these 4 are present in a patient who presented with recurrent oral ulcers, you can diagnose the case as Behçet's disease, right? Okay, that is about diagnostics. Now coming to the management, and before we go to management, one quick word, we have already heard about it, the large or medium vessel manifestations, right? So the large or medium vessel manifestations, if you talk about veins, it is about DVTs, right? DVTs involving the large or medium veins. And if you talk about arteries, the most common arterial manifestation is what? We have already learned about it. That is patients developing pulmonary artery aneurysm, right? Large or medium vessel manifestation. Otherwise, whatever we discussed in the past, in the last few slides, were all about the small vessel vasculitis, right? Okay. These are 2 important potential MCQ points, so remember about them. Now, coming to the management of Behçet's disease, right? So we can classify the cases as a different phenotype and we can have a different approach for them. Okay. So I want you to remember, when it is mucocutaneous disease, right? They are better treated with topical steroids, and if required, so the mainstay of treatment or the primary initial approach is to treat them with topical steroids. Like you have recurrent oral aphthous ulcers, we can treat you with say for example some steroid lozenges or steroid gargles or steroid paints. If that is not helping, yes, you can think of oral steroids. Similarly, if you have skin manifestations, you can try treating them with the topical steroids. If that is not helping, low dose oral steroids. Usually most patients who have mucocutaneous phenotype do not require large dose oral steroids, right? Okay. Now, if arthritis is the primary manifestation, or if it is a mucocutaneous with arthritis, which is a very common phenotype, right? Mucocutaneous with arthritis. In those cases, colchicine can be helpful, right? Similarly, apremilast, yes, the phosphodiesterase 4 inhibitor had been shown to be helpful in some subset of patients with mucocutaneous disease. The only point I want you to note here is that when apremilast was used, the effect or efficacy did not last long. So as soon as you withdraw the drug, patients start developing the manifestations again. On the other hand, when you treat them with topical steroids or oral steroids or colchicine, the effect lasted relatively longer in comparison to apremilast. Okay. So that is about mucocutaneous phenotype. That also applies to the arthritic phenotype because we're talking about colchicine here. Right. Now, CNS or neurobesets, right, or any other organ-threatening manifestation like a vision-threatening ocular disease. In such cases, the mainstay of treatment is high-dose steroids, right? Usually 1 milligram of prednisolone per kg per day, right, for an extended period. And once you have a good disease activity control, you can start tapering the steroids, right? High-dose steroids for salvaging the organ. So in case of CNS besets or vision-threatening ocular disease. Some number of patients may not really respond to steroids. In such situations, you can consider TNF-alpha therapy. Infliximab and adalimumab are the most commonly used ones, anti-TNF-alpha drugs. Infliximab and adalimumab. Okay, so that is the approach. Now, the third thing I want you to note, I think I should stress upon you again. If patient has presented with GIT besets, right, which is more or less going to behave like Crohn's, right? So in that case, you can treat those patients with sulfasalazine that can be used. And also, if required, you can consider TNF-alpha, anti-TNF-alpha therapy also, right? So that is the approach to a case of Behçet's disease. Now, before we wind up, a quick 3 or 4 point summary. The diagnostic criteria mandates you that patient should have the oral manifestations, but that is more of a classification criteria, though the wordings use diagnostic criteria. So you can diagnose a patient in the absence of oral ulcers. That point is clear. These patients with Behçet's syndrome have a strong correlation with the HLA-B51. That point is clear. In terms of gender distribution, males and females are equally affected. It is typically affecting the young males or females. And a young male, if he develops Behçet, is likely to have more severe disease. Right? In terms of eye manifestations, it is pan-uveitis or posterior uveitis, not anterior. Anterior can occur as part of the pan-uveitis. Right? So any patient, when you see anterior uveitis, there will be posterior also. It is part of the pan-uveitis. In terms of skin manifestations, I want you to remember pathologitis particularly because that is part of the diagnostic criteria. Okay. Now, in terms of organ involvement, CNS, like cortical vein thrombosis or the parenchymal lesions. And in terms of GIT, it is going to behave more or less like Crohn's disease. When it comes to treatment, it is primarily in the form of steroids, topical, low dose or high dose depending on the organ severity. If you have to think of an alternative or a second line drug, you can think of the anti-TNF therapy, infliximab or adalimumab. If it is GIT predominant, you can treat the disease entity just like you treat a Crohn's disease patient, right? If it is arthritis predominant, you can use colchicine as your primary drug. If that is not helping, the other immunosuppressants like azathioprine or methotrexate may also be considered. Okay. So that is a brief summary, guys. Thank you for listening. We will be discussing another topic in the next video.